Oxycon. I'm one of the urologists here at the Mayo Clinic in Phoenix, Arizona. I specialize in female pelvic medicine and reconstructive surgery. This does focus on female and male incontinence, and today we're going to talk about surgical treatments for males with incontinence after prostate treatments. Typically, this is prostate cancer treatment, but this might also be following things like BPH treatments. Incontinence after treatments for prostate surgery have varied all over the map, and there's been a decline in the rates of incontinence as therapies have improved and people have become more specialized in doing this. We've done nerve-sparing techniques. However, there's still a substantial number of men that may still struggle with incontinence after a year to two post their treatment. As it stands, the American Urological Association came out with their guidelines this year and have put out that we can offer men surgical treatment for their incontinence, bothersome stress urinary incontinence at 6 months if they've continued to have bothersome leakage despite conservative therapies. And at 1 year following treatment, if they're still leaking and bothered, then we should be offering them some further treatments. So then the question comes up, what are some treatments that are available? And there are a number of different procedural or surgical therapies that exist for post-prostatectomy incontinence. This varies anything from urethral bulking treatments, which is done commonly in the office, to a newer therapy, which is adjustable balloons, which came out in 2017, and there are some of our more tried and true therapies, which include the artificial urinary sphincter and the male sling. And the timing can be anywhere from 6 months to a year following the treatment can be when we first offer it. What do we do if you have incontinence immediately following your treatment and up till that 6-month point? Typically, we offer some conservative therapies, and this falls under the category of pelvic floor exercises, or sometimes also known as Kegel exercises. Your doctor might talk to you about these. These are exercises that you do where you squeeze the pelvic floor muscles. The question comes up, how to identify my pelvic floor muscles? Typically, we'll say that if you're going to the bathroom and you're urinating, you would like to try to stop your flow of urine right in the middle, and that will help you to identify what is the muscle that needs to be exercised. Another way, if you're unable to actually squeeze it during your flow of urine, you might try to stop from passing flatus or something like that. That would be the same muscle complex that you would exercise. Some men also find a lot of benefit from working with a pelvic floor physical therapist because they can help you to identify the muscle, and they can give you a number of exercises that you can work on with them to see if you can get some strength to those muscles back that will help to improve your incontinence. By 1 year, where you're at with your incontinence is probably where you're going to be. And if you've done Kegel exercises and it hasn't been effective at this point, and you're still bothered by it, then it does warrant further investigation and talking to a specialist that might be able to offer you some more. So today I'm going to focus a little bit more on the most commonly performed procedures, or the ones that are probably better for patients that has been shown in the literature. I mentioned urethral bulking agents and the newer therapies like the adjustable balloons. Urethral bulking agents typically are not recommended to be used for males with post-prostatectomy incontinence because they very much lack efficacy and durability, meaning they don't last that long and just doesn't work as well. So today we'll focus on the male sling and the artificial urinary sphincter. The question comes up, how are they similar and how are they different? So the male sling and the artificial urinary sphincter are similar in many ways. They both are basically giving some control around the urethra where there's been maybe some impact to the sphincter to regain some continence. The surgeries are done both through an incision, which is behind the scrotum. We call that a perineal incision. Both of the surgeries can be an outpatient procedure. Both have very acceptably appropriate rates of improvement or cure for incontinence rates. And then how are they different from one another? The male sling tends to be a small strip of mesh, which we place right underneath the urethra. And once it's placed, you get your continence from the day you have surgery. This is in contrast to the artificial urinary sphincter, which is a cuff that's placed all the way around the urethra, and you don't get your continence until the cuff is activated, typically about 6 weeks after surgery. The cuff also has a number of different components to it, which we will review in a second. So there is a higher chance for mechanical failure of any of the different components. The artificial urinary sphincter also does have a higher rate of potential mechanical failure, erosion, or infection of the device compared to the sling, which is exceedingly rare for those issues. However, the artificial urinary sphincter is our gold standard as it tends to have the highest rates of satisfaction, cure, and is our last resort often when multiple other types of treatments fail. And very rarely, if these treatments fail or a patient's not a candidate for these failures, there's always the option for a urinary diversion. For the artificial urinary sphincter, you need to have good manual dexterity and you need to be able to manipulate the device. So if you don't have good use of your hands, then the artificial urinary sphincter may not be a good option for you. So right now I'm just going to show some photos of the difference between the sling and the artificial urinary sphincter. Here you can see on the right side, this is a demonstration of the male pelvis. This is the male bladder. This is the urethra that exits through the penis, and the prostate in this photo is missing. You can see the location in which we would be placing the sling, which sits in what we call the bulbar urethra, sitting close towards the neck of the bladder. This is a front-on view of the male. He's laying backwards, and his legs are coming up into the sides this way. This is where the sling sits, right underneath the urethra. This is an example of the advanced transobturator sling, where the arms of the sling are coming through these foramen we call the obturator foramen. So this is how the male sling sits. There are some other types of slings that have been on the market, some which have been removed off the market. This is in contrast to the artificial urinary sphincter. So again, this is a male pelvis, a side view. This is the bladder. Again, you have the urethra. There's a couple of different parts to the artificial urinary sphincter. There is the cuff, which sits around the urethra. You have the pump, which rests in the scrotum, and a small reservoir, which sits behind the pubic bone. The way that the artificial urinary sphincter works is that there's a small amount of fluid within the system. Most typically, the fluid rests within the reservoir system. The pump is responsible for moving the fluid back between the reservoir and the cuff, and back from the cuff and into the reservoir. So in an activated state, when we're trying to have continence, the cuff is filled with some fluid, enough that is able to squeeze the urethra closed and keep you continent. When it comes time to urinate, you squeeze the pump in the scrotum that will deliver the fluid from the cuff into the reservoir for about 1 minute to 2 minutes. While the cuff is open, you're able to urinate either because your bladder works or with some abdominal pushing, and then you'll be able to hopefully empty your bladder, and after 1 minute or 2, that cuff will re-inflate on its own. And that is the difference between the sling and the artificial urinary sphincter. When we are determining candidacy or if you're eligible to get any of these treatments, it's very important that we get a very good history, so it's important that you're able to describe your incontinence. There are different types of incontinence, and it's very important that we are placing these types of devices for the type of incontinence we call stress incontinence. That is the incontinence that you experience if you are to do anything that raises pressure within your belly, such as coughing, sneezing, running, jumping, lifting, bending. Typically, men will say, when I do those type of activities, I have no control and I'll squirt urine outside of my penis. This is in contrast to the type of incontinence that we call urgency incontinence. That's incontinence that we experience if you have a sudden onset of a desire to urinate, which is difficult to defer. So you have an urgency to get to the bathroom. You might not make it in time. You might be urinating on your way to the bathroom. That may be a problem that's happening with the bladder. And sometimes it's important that we actually manage the bladder symptoms before we target the stress incontinence, which is more often a sphincter or bladder neck problem. So to evaluate this, after we get your history, we may do some further testing. We may do an exam where we ask you to stand, cough, bend, squat, and see if we see any of that leakage with any of those activities. We will obtain some urine and some blood work. We might have to do some more diagnostic testing, including tests such as something we call a urodynamics. We might have to do some imaging studies to just make sure that we're doing the appropriate therapy for you. You'll need to be medically optimized to undergo any surgery, so we'd have to make sure that there's no other issues that need to be controlled, such as any heart or lung issues. And we have to be sure that you would be able to use the device carefully. All right, now we'll talk about what happens during the surgeries. First, we'll describe the male sling, and then I will describe the artificial urinary sphincter. Both surgeries are typically done through a perineal incision. That's an incision that's made behind the scrotum and between the scrotum and the anal sphincter. It's about 4 centimeters in length. For the male sling, we like to identify the urethra, and we also then like to identify what we call the central tendon. That's where we're going to be placing our sling. We cut the central tendon a small amount so that we can get proper placement, where we will then place the sling. We use trocars, which will then exit through those obturator foramen, which I showed on the photo, and they'll exit through small stab incisions on the groin. And then we will tension the sling under visual guidance using a flexible cystoscope, which is placed into the urethra to make sure we get good closure of the urethra, or what we call coaptation. This is somewhat similar to the artificial urinary sphincter, but that's also done through the perineal incision. We identify the urethra. We dissect the urethra free so we can encircle around it, and we take a measurement with a measuring tape around the urethra so then we can decide what size cuff we're able to use. We then also like to make a separate incision, usually in the lower quadrant, left or right, depending on your surgical history and which hand is your dominant hand. And we like to place the reservoir behind the pubic bone through that separate incision. This incision is preferred by some providers. Some providers don't do the incision, and rather they'll just go through what we call your inguinal canal to place the reservoir. Once we get the reservoir in proper position, we put a small amount of fluid into it, and then lastly we place the pump into the scrotum. There's tubing that connects all these devices together, and once that's all connected, we like to check our device to make sure that it's cycling properly and will work well once we activate the device completely. Once we complete the surgery, the device will be left in a completely deactivated position. I have an example of the system here. This is the cuff that will be resting around the urethra, the pump, which will go into the scrotum, and then the reservoir, which will go behind the pubic bone. Immediately postoperatively, when you wake up from both of these surgeries, you'll have probably glue over the incision that's in the perineum. If you had the artificial sphincter, you may have some gauze over your lower quadrant incision. There'll be a lot of gauze and a scrotal support, and you may have a Foley catheter. That Foley catheter most likely will be removed before you go home. Depending on the provider's choice, you may have the Foley catheter for a day or two following the procedure. Both of these procedures can be done outpatient. If you're discharged to home, the medications that you will be prescribed most likely will include a pain medication, a stool softener, and some antibiotics for about 5 days. Postoperatively, you may have some soreness over the incisions, which hopefully will be managed with some pain medications, but you can also help to alleviate this with ice and elevation of the scrotum. It's also important to wear some compressive wear, such as a scrotal support, to prevent any scrotal swelling. There will be some activity restrictions, so about 6 weeks of avoiding any kind of heavy lifting, typically more than about 10 pounds. Avoid twisting, bending, squatting, or activities which raise or elevate your heart rate or blood pressure any significant amount. So really just taking it easy for about 6 weeks. However, not avoiding activities completely, as it's very important to ambulate following any kind of surgery. If you have an artificial urinary sphincter, you will still be incontinent as your device will not be activated for 6 weeks, so you may still have some urinary soilage. It's important to make sure that your wound is cleaned and dried with some regularity to avoid any irritation to the wound. Following either of these surgeries, you'll have a follow-up in about 2 weeks to make sure that all is going well, and then at 6 weeks. Before these visits, you may have a visit that requires you to urinate into a tub, and we'll check a small ultrasound to make sure that you're not having any retention of urine that we're not comfortable with. One last point is following artificial urinary sphincter placement, it is very important that going forward you notify any healthcare provider that you have this device. Some people will carry a medical bracelet or a medical card with this information in case there was an emergency. Because the cuff keeps the urethra closed at all times, it's very important that nobody place something like a Foley catheter or something into the urethra that could damage the device or cause it to have a problem such as an erosion. Urethral bulking procedures typically have very modest amounts of improvement, about 50% with about 6-month durability. There are multiple different types of urethral bulking agents. There's very small studies on these, and some of them are associated with some risks of migration or urinary retention. There's much more data that exists for the male sling and the artificial urinary sphincter. Several studies have demonstrated very good improvement or cure rates. The male sling improvement rates range anywhere from 4 to 100%. On average, it's about 70% if you compile all the studies together. These studies tend to be done on patients who have not undergone radiation or who do not suffer from severe urinary incontinence, which typically tends to be defined as use of more than 5 pads per day or more than 500 grams of leakage in a 24-hour period. The artificial urinary sphincter, which again I mentioned is the gold standard procedure, has had several studies which has demonstrated very good success rates or improvement rates. However, the artificial urinary sphincter does have very well-known rates of mechanical failure. And there are also other complications associated with this, including erosion, which can be reported as up to 5% of the time, or infection, which is 1 to 3% of the time. With the use of a new antibiotic that they place on the device called inhibisone, those infection rates have gone down. Other things that can happen with the artificial urinary sphincter is what we'll call urethral atrophy, where the walls of the urethra thin out from the constant pressure, and that can lead to recurrent incontinence again. And finally, there can be mechanical failure. or just one component or the entire component, all three components of the device fail. Maybe there's a fluid leak or the pressure regulating balloon no longer compresses the urethra, and that may require a revision or entire replacement of the device. Typically, if you've had your device in place for 3 years, it's recommended that you place an entirely new device at the time of revision. The artificial urinary sphincter does have very high satisfaction rates, with reports of 92% of men reporting that they would get the device again and 96% of them recommending it to a friend. The complication rates for the sling have been reported as urinary retention. Rates of erosion are extremely low, however, have been reported, and if that were to happen, then the sling does need to be removed. One of the issues that often arises is if a patient needs further therapy for their prostate cancer. Typically, if maybe the PSA were to rise or the patient had a high-risk prostate cancer and they need other adjuvant therapies, and how would that impact their continence? Radiation therapy is the one that typically plays a bigger role compared to hormonal therapy. With radiation therapy, you can have some further deterioration of the tissue. Some men may undergo a prostatectomy and be completely continent, and then they go through radiation and then they develop incontinence. Or men may have incontinence following prostate cancer surgery, and then they go through radiation and it may worsen. And then the question comes up is, how does radiation therapy impact the treatment? Typically, overall, radiation does seem to damage the tissue and can be an ongoing effect. So if any therapy is going to be done, several providers will often choose to do it before the radiation has been given and the device is completely healed before administering the radiation. Several studies have been shown that patients with radiation that then subsequently go on to get sling or artificial sphincter do have higher rates of the complications as described before, including erosions and infections and need for revisions or failures. Any new therapies that are coming for urinary incontinence, there's several studies in place. As I mentioned, there is the adjustable balloon device that was released in 2017. So far, this is showing that there's maybe about an improvement or cure rate of about 60 to 80%. However, there is a higher rate of needing to be removed or revised compared to male sling or artificial urinary sphincter even at 2 years. So this may be something we have to look into a little bit further. The artificial urinary sphincter was developed in the late 1970s, and for the most part, it hasn't really been changed because it's worked pretty well as it is. However, there have been some suggestions to improvements that can be made on the device, making it a little bit more user-friendly. So we'll see about any of those implementations if they have any benefit compared to what we have now. I'm Oxa Khan here at the Mayo Clinic, Phoenix, Arizona Urology Department, and I thank you so much for taking the time to listen to my review on surgical management options for men following prostate treatments.